Good afternoon, everyone. I'm here to introduce Dr.N. Ramakrishnan. He is an American board certified in internal medicine, critical care medicine, and sleep medicine. He is currently the director of critical care services at Apollo Hospitals. He is a senior consultant in critical care and sleep medicine. He is going to give us a talk on obesity management and easy lifestyle changes. It's a must-needed topic for all of us. Graduated from Stanley Medical College, he worked in UK and USA for 13 years, returned to India in 2003. He was very instrumental in developing www.icu.consultants.com, first of its kind private practice group of critical care specialists. This group has also successfully established TACT Academy for clinical training. It is India's first simulation-based healthcare training center and has won several awards and also listed in Limca Book of Records. It has also been instrumental in developing social doctors by training non-medical persons on life-saving skills. He was honored with fellowship by American College of Physicians, American College of Chest Physicians, American College of Critical Care Medicine, American Academy of Sleep Medicine, Indian College of Critical Care Medicine, and Indian Sleep Disorder Association. He has received a lot of prestigious awards. To name a few: Best Doctor Award from IMA, Tamil Nadu MGR Medical University, Presidential Citation Awards from Indian Society of Critical Care Medicine, Vocational Excellence Award from Rotary Club, Acharya Award for Healthcare Education. He is a speaker for several national and international medical conferences. He has authored 4 books in Tamil for the public on issues like ICU, sleep, organ donation, etc. He was also invited to meet the then President Dr. APJ Abdul Kalam, who appreciated his contribution to the field of critical care and sleep medicine. Over to you, sir.
He is the only person who has AB obesity. In India, he is the only person who has AB obesity. It's a rare thing because American board giving honest degree on obesity. We rarely have any person.
Laptop put it. Yeah, I've given my pen drive.
Oh, okay.
They wanted a connector. The PowerPoint, yeah. Second. Good afternoon. Thank you for the invitation. It's a real pleasure to be here with all of you. I think as more and more hospitals are proliferating, I think I need to look extra carefully at the invitation. Unfortunately, I went to the Vadapalani Kaveri. So that was the reason I got delayed. My talk was scheduled at 3, so it still reached on time because it's a Sunday and I could quickly move from there. What I will try to do in the next about 25 to 30 minutes, after which we can probably engage in a conversation if required, is primarily focus on how sleep and obesity are linked. In what way? Is it sleep problems causing obesity, obesity problems causing sleep, and then finally focus a little bit more on obstructive sleep apnea, which is the first thing that comes to us in mind when we are thinking about obesity. So now we are all talking about non-communicable diseases now, increasingly, because the WHO is focusing on non-communicable diseases, and it is clearly stating that NCDs or non-communicable diseases are responsible for more morbidity and mortality than even communicable diseases or infectious diseases. Of course, those 2 years of COVID, we thought of nothing other than communicable disease. But again, the focus is back on NCDs. We talk a lot about various NCDs. And when we think of NCDs, what comes to our mind is obesity, hypertension, diabetes, heart disease, cholesterol, dyslipidemias, cancer. But we often forget one problem that's probably linking all of this and is probably more common than several of these, and that's sleep disorders, because sleep disorders can lead to obesity, obesity can lead to sleep disorders. Same thing with hypertension. Hypertension can be a risk factor for obstructive sleep apnea. Sleep apnea can cause hypertension. Same is true for diabetes, heart disease, stroke, all of those. And we often forget sleep disorders, and that's what we will focus on today. Now, sleep problems are extremely common, and it's thought that sleep apnea is at least as common as asthma and is often underdiagnosed. We don't think about it in several of the patients. And if we don't treat the sleep problems, they can be serious. Like sleep apnea, if untreated, can lead to uncontrolled hypertension. A lot of people are on 2 or 3 or 4 medications with poor control of hypertension, and it could be related to their underlying sleep apnea. And once you start treating that, their blood pressure gets under better control. Same is true of diabetes. One of the commonest referrals we get is when the HbA1c is persistently high, you're not able to control the diabetes despite giving them adequate medications, despite doing other measures. And if they are snoring, or if they have sleep apnea, or if they have insomnia, then we need to treat that, and that would improve the control of diabetes. Same for cardiovascular problems and stroke. And we must remember that these are often treatable. Sleep disorders are very much treatable, and you don't need medications for everyone. Sometimes it's just, like people with shift work disorders need a lot of counseling on how they should, like when they should eat, what they should eat, when they should sleep, how they can sleep. So there's a lot of counseling, a lot of lifestyle changes that are required in these people. So we need to treat them in whatever way is appropriate. And as I already mentioned, sleep disorders are very much underdiagnosed. There are reports saying that even 90 to 95% of sleep disorders are probably underdiagnosed. Every one of us at some stage would have had some difficulty in sleeping. But again, that doesn't qualify as insomnia. If it is persistently there for a longer time, and if there is no obvious reason, that's when you need to think about it and treat. And as I was mentioning, sleep disorders are associated with significant comorbidities and mortality. And therefore, there are a lot of direct causes, there are a lot of indirect causes. We'll talk about it. Sleepy driving is a major problem. Like people who are on the wheels and like sleepy can lead to accidents, and that can cause issues. Same thing is true for industrial accidents. It is even thought that the Bhopal tragedy, Exxon tragedy are all probably in some way related to somebody who was sleepy while at work. So definitely these are all very expensive sleep disorders, and we need to think about the direct and indirect cause that it could incur from those. Okay, so as a sleep specialist, what kind of problems do we see in our sleep center? Number one is insomnia, people who are unable to sleep. And as I mentioned to you, there are different types of insomnia. Short-term or acute insomnia, which is usually less than about 3 months duration and often unprovoked, but sometimes they will have a definitive reason. Something happened at home, or some health issue, or some family member had a problem. Any of those can lead to short-term insomnia. And if you don't treat it, it can sometimes get prolonged, and it can lead to chronic insomnia, as in several of these. Without getting into details, we see people who have sleep onset problems, or what we call sleep onset insomnia. Some people have sleep maintenance problems. So they go to bed on time, but they are unable to maintain their sleep and wake up very early. Now, those who have trouble sleeping at some stage will see a doctor because they cannot cope with that for too long. The opposite is what happens with excessive daytime sleepiness, where people feel that I have no problem sleeping because I can sleep anytime. I can sit and sleep in a lecture. I can sit and sleep, when I'm driving. I can, anytime I can sleep. And they think it is not a problem when in fact it is a problem. So excessive daytime sleepiness is more of an issue, and we'll talk a little bit more about it on the issues. And the third group of people are those who have what we call fragmented sleep. They go to bed on time, they wake up on time, but in between wake up several times. Men with prostate problems may wake up several times at night to use the bathroom. Women with what we call restless leg syndrome, like they may have numbness, pulling cramps, any of those. I said women, but anyone can have it, but more common in women. So restless leg can wake people up several times. Diabetes, if it is not well controlled, can wake you up several times. Asthma, if it is not controlled, can wake you up at night. So any of these can lead to fragmented sleep pattern. The fourth group of people we see are those with what we call parasomnias, which there is something abnormal happening during sleep. They go to bed, they sleep, they are not aware, but sometimes they are sleepwalking, sleep talking, sleep eating. Sleep eating disorders are not uncommon. There are people who come to us saying they don't even know that they are eating at night. They prepare and keep it in the fridge. They eat, they don't know about it, and they're not lying. They are actually sleeping, and they can go and have something to eat. So all these are what we call parasomnias. Circadian rhythm disturbances, extremely common in a city like Chennai, where we are posting a lot of BPOs, IT companies, where they are working for UK time, US time. I just came back from US 4 days back, and I still feel a little jet lagged. But you can think of people who are jet lagged every day because they are working for the US time and they have to sleep during the daytime, or working for the UK time and is having trouble. So any of these can lead to our rhythm disturb. Our body has a clock. Okay, so the clock likes to sleep at night somewhere between 9 to 11 p.m. and wake up somewhere between 5 to 7 a.m. and in between we sleep. But these are people who are trying to acclimatize to a whole different time on a regular basis, but try to sleep at night on a weekend, which they find it very difficult. Again, a lot of these can be treated with lifestyle changes. Now, in our sleep clinic, as I said, if I told you the chunk of our problem is probably insomnia, which is about 45%, and obstructive sleep apnea, which is about 47%. This data is a few years old. But we also see a lot of circadian rhythm disturbances, restless leg syndrome, nocturnal seizures, bruxism. Any of those can be an issue. Now, this is a study we published almost 15 years back. So we looked at 1,000 consecutive patients who presented to our sleep clinic. And interestingly, we found that 42% of them were referred by physicians. Well, close to 60% presented themselves. So often they look up at media. Nowadays, there are a lot of Google doctors, so they'll all look up somewhere and find that, they are having a sleep issue, whether it is sleep apnea, whether it is parasomnia, and then they present to us. So a large number of people are still presenting themselves, and, increasingly the media is also creating awareness, which seems to be helping. This is an earlier one, but there are a lot of magazines and online media that are reporting on sleep related issues. Now, before I talk about the sleep problems, I do want to specifically mention about what a normal sleep pattern would look like. So if you go to bed somewhere around 11 p.m., this is what we call a hypnogram. So you can see that if you look from 11 p.m. to 7 a.m., which is an 8-hour period, so you can see wake, R stands for REM, N1 is stage 1 sleep, N2 is stage 2 sleep, and N3 is stage 3 sleep. So there are 4 stages. N1 is very light sleep, which is just when we enter into sleep, usually just about 3 to 5% of our entire sleep. The main sleep pattern that we have is stage 2 or N2, which is almost about 50% of our sleep during night. And stage 3 is deeper sleep, or what we call slow wave sleep. And that, as you can see, is more prominent in the first half of the sleep. Okay, so you get a lot of the stage 3 sleep, and that's why, the good old grandma used to say, the child has to sleep well to grow well. Why? Because in stage 3 sleep is when our growth hormone gets secreted, and therefore, like the child grows better if they are getting the good deep sleep. And the last one that you see on top is R, which is in green circles. So that's the REM sleep. And what happens, as you can see, is roughly about every 90 to 120 minutes, roughly about 1.5 to 2 hours, we have a REM period of sleep. Now, as you can see, the first REM sleep is fairly short, just about 5 to 10 minutes. And as we progress through the night, you can see that the last one is fairly prolonged, about 45 minutes or so. Now, the interesting fact about REM sleep is during REM sleep, our body muscles are completely paralyzed. Okay, you cannot move the body, but the eyes are moving. So it's a rapid eye movement, but the rest of the body, the muscles are almost having an extremely low tone and they are not moving. The best way to remember this is sometimes a small child may sleep in a sofa, and when you try to carry them and put them in the bed, they are very floppy because their muscles are losing their tone and they're probably in the REM sleep. Another interesting fact about REM sleep is REM sleep dreams are the ones that we remember. We can have dreams during any stage of sleep, but if you have it during REM sleep, you remember it. That's why most of us would wake up in the morning with a dream, because that's when the REM sleep is prolonged and we may be having a dream and we may wake up. Just a few trivia, so that we understand the pattern of sleep. And as I said, then our body's propensity to sleep is highest during the night. If we sleep somewhere between 9 to 11 p.m. and wake up somewhere between 5 to 7 a.m., and within this period, if we can sleep about 6 to 8 hours, that's the average adult what we require, preferably at least 7, but our lifestyle is shrinking our sleep and therefore we accept 6 or even lower. But this is how our pattern would be. Now, it has clearly been shown that the quantity of sleep is absolutely important to maintain healthy weight. We are more and more not talking about weight loss management or weight gain. We're talking about what is the healthy weight. So it's a healthy weight management or weight wellness management. Those are the terms that are increasingly being used. And as you can see, if somebody sleeps about 7 to 9 hours, okay, and I'm talking about all age group, but this was done in pediatric group as well, this study, you find that their odds of developing obesity is not much. Okay, so it's 1.0. But the odds ratio go up as you reduce your sleep. You can see that at 6 hours, your odds ratio is almost 1.08. 5 hours, it goes to 1.22, and 4 hours, 1.37. So the lesser your sleep, your propensity to get obese is much, much more, or the chances of you developing unhealthy weight is much more. That's what we need to keep in mind. Now, unfortunately, childhood obesity is increasing significantly. You see, we all love chubby children, but they're not necessarily always chubby. They may be developing unhealthy weight, and this is related to various aspects. So, I can really start the cycle from anywhere, but let me start with reduced physical activity. I'm sure all of us remember going out of the house and playing in the evening. Doesn't happen with children anymore. Either they are going for more classes for NEET coaching from kindergarten, or they are starting to start playing inside the house. So really the physical activity is significantly reduced. Okay? And that by itself can increase your body weight. The fact that you're not burning the calories is obviously going to increase the weight. Now, on top of it, children go to bed very late for whatever reason, whether it is related to screen time, whether it is related to working late. And there's a lot of, I think this is a generation that talks a lot about mental health. If you have heard about it, they all say, oh, I'm burnt out, I'm tired. I'm talking about adolescents and, 20-year-olds, a lot of pressure, a lot of stress, all of them. And so they often go to bed very late. And during that time often are on screen and try to wake up late if they can. But unfortunately, they have more classes in the morning or have to get to school early in the hour. So they are shrinking their sleep time. So the sleep restriction leads to, again, a weight gain. And how does this do it? There are a lot of changes in the metabolic profile that happens within our body when our sleep is reduced. Number one, there is increased ghrelin. What ghrelin does is it makes you have a higher appetite and you want to eat more. Okay, so the ghrelin level goes up, whereas the leptin level is reduced. What leptin does is gives you satiety. It feels like you've had enough and you're full. So you want to eat more and you're not feeling full. So the chances of consuming is much more. And children who have associated mental health issues, if they are tired, if they're burnt out, if they are stressed, also have a tendency to binge at night on carbohydrates. Okay, so a lot of them would go and eat sweets or like binge on some carbohydrates, and that can also increase the chances of them having a weight gain or an unhealthy weight gain. So there is a lot of changes that happen with changing sleep patterns, reduced sleep time, and the obesity itself can also increase several of these hormones, and they do not have a satiety and they tend to consume more and more at the wrong hours and unfortunately the wrong food as well. At 2 a.m., I live in Ananagar. If you walk on the Second Avenue, you would find that the hottest selling thing is biryani. Okay, 2 a.m. biryani, 4 a.m. biryani. I don't know how people can eat at any time. I mean, at that time, a full meal. I know that several of them are working in the night, whatever, but I think the entire sleeping habits, eating habits, everything has changed, and this seems to be creating a cycle. So this is just to reiterate, ghrelin, as I said, signals hunger and stimulates appetite. We also have the growth hormone secretagogue receptor, which stimulates food intake and growth hormone secretion, and that can also be affected, and leptin, as I talked about. Okay. With this, I just wanted to move on to a patient history and how we deal with obesity-related sleep apnea and obesity hypoventilation syndrome, and we'll then start taking questions as you want. So this is a young person, 45-year-old gentleman, admitted with a stroke. He had a right-sided hemiparesis. This is a real-life patient. I'm not made this up at all. His past medical history was significant for uncontrolled hypertension, uncontrolled diabetes. He's had coronary artery disease. He's had multiple stents. He's had hypothyroidism. He's also noted to be obesity. So classic. I'm sure all of you are seeing people like this. Hypertension is very common in the 30s nowadays. Diabetes is very common in the 30s and 40s. So obesity is getting increasingly common. On one hand, you see this, and you also see a lot of marathoners, runners, gyms are busy. That's happening, but still, there is unhealthy weight gain in several people. Now, superficially, this looks like, yeah, this guy has all the risk factors for a stroke. He already has, bad cholesterol levels, he's hypertensive, diabetic. All these are risk factors for any kind of cardiovascular or cerebrovascular disease. So you can blow it off. But then when you introspect here, and what this person had is like, over a period of time, he's had this problem. And when I asked him, he was snoring, and he has had several days when he wakes up not feeling fresh. He's not able to perform his work. He's feeling fatigued. He was a non-performer at work and therefore got fired from the job. And he slept while on wheels and therefore had several accidents for which he's been in the emergency department. He's had orthopedic surgeons looking at him. He also went through depression because his wife felt that he was lazy and always sleeping. So the excessive sleepiness was branded as laziness by her. And he went through a divorce. He's gone through depression. Psychiatrists have seen him, neurologists, general medicine for hypertension, diabetologists, endocrinologists for, hypothyroidism and diabetes. Cardiologists have seen. There are so many people who have seen, but he has had sleep apnea for many, many years that was not even diagnosed or treated. Okay. We often forget about this as an independent risk factor for all this. Sleep apnea can be an independent risk factor, and as you can see, a lot of them are sleepy at work.
Who's the second president? Who is the president?
Pranab Mukherjee. Okay. So we'll move on and talk a little bit about sleep apnea, which is extremely common in obese people or in unhealthy weight. So it's a disorder where the breathing is interrupted. So basically what is happening is when we sleep, as we get into deeper sleep, our body muscles are relaxing. And when the muscles are relaxing, the muscles around the airway are also collapsing. Okay, so the pipe becomes narrow. Imagine you take a small pipe and you blow through it and you make a noise. That noise is snoring. So every time you're breathing in or out, you're making a noise. Now, as the pipe becomes narrower and narrower, the noise becomes louder and louder. But the breathing becomes slower and slower because you're getting less air to the lungs. So, and that's what we call as hypopnea, where the breathing is slowing down. At some stage, when the pipe closes fully or the airway closes fully, what happens is there is no air movement to the lung and you stop breathing. Okay? And that's what we call as an apnea. Okay? And when the breathing stops, the brain gives a signal saying wake up, and you go, and they just wake up. Okay? So often people who are snoring are unaware that they are snoring. And it's the bed partner, or sometimes in a flight or a train, somebody observes. And what people are worried about is, yes, the noise bothers them, but what bothers them even more is when there is no noise, because they know that they have stopped breathing, and they often try to push them to one side, because in the supine position, the chances of the airway being blocked is much more. So if you lie down on the sides, the airway obstruction gets reduced. So often the wife would just push the husband, or the husband would push the wife, whichever way, turn to one side, and then they start breathing again and it becomes normal. So this is the classic presentation. And patients with sleep apnea have both nighttime symptoms and, more importantly, daytime symptoms. So what happens at night? Loud snoring, which often is perceived by others. Witness pauses in breathing, where they're stopping breathing or having apnea. Sometimes the person himself or herself will say that they're choking and waking up, and they may have dryness of the throat at that time because they're mouth breathing. That can be the thing. Feels that the sleep is somewhat restless. They often wake up to go to the bathroom. And I do want to mention here specifically that the visits to the bathroom or nocturia is thought to be related to the fact that people with sleep apnea have increased secretion of what we call atrial natriuretic peptide. So that seems to be causing the diuresis, not anything else. So once you treat the sleep apnea, the number of visits to the bathroom might come down. Of course, if it is related to uncontrolled diabetes or prostate enlargement, you need to address that as well. But if it's pure sleep apnea, it gets addressed once you treat them. Now, because they are having multiple episodes when their breathing is slowing or stopping, their oxygen level comes down and the brain wakes up. They may not physically wake up, but the brain wakes up. So they're not really getting into deep sleep. And therefore, the next morning when they get up, they often say that I sleep for 7 hours, but I don't feel fresh. As soon as I get up and I'm with my newspaper, I sleep again, or with a coffee, I feel like dozing again, have a headache. During the daytime, when I'm at work, if I'm sitting and doing nothing, I feel like sleeping. Okay. Then it gets to a point where even I have to concentrate when I'm driving or anything, when I'm operating on a machine, I feel sleepy. Some people feel irritable, all the time. They just feel like, the lack of oxygen seems to make them very, very irritable. Some of them can have memory issues. So all these are common symptoms. And of course, as I said, it gets to a point where they sleep while driving, which can lead to accidents, and they can have industrial accidents related to sleepiness. Okay. Now, what are the risk factors for sleep apnea? The number one thing is obesity. Like when we think about sleep apnea, often we think of an image where somebody is extremely obese and therefore they're having sleep apnea. Sure, a lot of studies have been done where 2/3 of the patients with sleep apnea may have significant obesity, more than 120% of the predicted body weight. But I just wanted to remind that in India, we see a lot of non-obese patients with sleep apnea. Okay. It may be related to our craniofacial structure, we don't know. It may be related to our central obesity, particularly in middle-aged men. But we see a lot of non-obese sleep apnea, but world over, obesity is the single highest risk factor for sleep apnea. Okay. Now, we are moving away from just measuring body mass indexes, particularly when we are dealing with sleep apnea patients, because the neck circumference is a much better predictor than the overall body weight. Okay. It's thought that men with a collar size of 16.5 inches or more, women with neck sizes of more than 15 inches or more, may be at higher chances of developing sleep apnea. And that seems, the shape of the airway seems to be determined, and that's what you need to look at. Now, the even more important thing is, if you diagnose somebody with sleep apnea, it's absolutely important to talk about healthy weight management and losing some weight. And it's noted that when they lose even 5 to 10% of their current weight, which may be nowhere near normal. I mean, I see patients with 130, 140 kilos. I'm talking about losing 7 kilos out of the 140, which is nowhere near normal for their height. But still, you would find that there is significant change in their sleep apnea or overall management. So it's very, very important to focus on that initial weight loss in these patients. A lot of them, when we start treating, would lose some weight initially because they lose the water weight. Okay, once you put them on CPAP, sometimes you find that because of the positive pressure, the extracellular water level seems to come down and they lose weight. But it is important that you keep pushing them, adhere to a strict diet and exercise pattern so that they can lose some weight. And this was a study that we did with MV Hospital in Royapuram, and we found that a lot of diabetic patients whom we saw who were having uncontrolled diabetes, when they were referred for sleep apnea, several of them were not even obese. Like with much lesser BMI, we found that they had a high incidence of sleep apnea. Now, if we suspect sleep apnea in someone, what do? You need to do a sleep study, okay? And there are different options for sleep study. The two most common ones are what we call the portable sleep study or the level 3 sleep study, which can be done anywhere. It can be done at home, it can be done in a hospital, it can be done anywhere, where all you are looking for is the cardiorespiratory channels. All you are looking for is how are they breathing, their nasal airflow, how is their breathing pattern, the thoracic and abdominal pattern, how is their pulse oximeter, it's a saturation. That's all. Now, the advantage is it can be done anywhere. The disadvantage is you don't even know if this person slept on the day you hook them up to the sleep study. So sometimes I've had people who have florid symptoms of sleep apnea. Somebody has done a sleep study and said it's normal or it's mild sleep apnea. And then when I talk to them, they'll say, oh, I didn't even sleep that night because with all those wires, I couldn't sleep. Now, sleep apnea happens only during sleep. So if they didn't sleep, you're not going to be able to diagnose the problem. So that's the limitation. If you have a high index of suspicion of sleep apnea, you can do a portable sleep study. And if it comes positive, it is helpful. If it comes negative, take it with a pinch of salt, look at the history again. And if needed, we can do what's called a level 1 sleep study. That's the gold standard, what we call polysomnogram, which can be done only in a sleep lab. And this is a portable sleep study, which can be done anywhere. And here in the polysomnogram, we are looking at EEG channels, we are looking at nasal airflow, we are looking at chin EMG, we are looking at chest belts to see how they are breathing, pulse oximeter, EMG to monitor for leg movement. So several things are looked at, and that's the way we can look for sleep apnea. Now, the numbers that are important are the oxygen level and what we call as apnea-hypopnea index. Basically, what we are doing is we are counting every time their breathing is slowing or stopping, and we average it per hour, and that's what we call as apnea-hypopnea index. And if that is less than 5, then they are primary snorers without significant sleep apnea, or it may be normal. If it is 5 to 15, we call it as mild sleep apnea. 15 to 30, it's moderate, and more than 30, we call it as severe. Okay. Just quickly, I do want to mention again that sleep apnea, particularly moderate or severe, has clearly been associated with poorer glucose control in patients with diabetes. And the more severe the sleep apnea, the chances of the diabetes being poorly controlled is much, much higher. And once again, same concept. As you can see, sleep apnea leads to intermittent hypoxemia, sleep restriction, sleep fragmentation. All of this again can worsen the obesity because we talked about the hormones, the ghrelin, the leptin, and all of those. And all of these can also impact your blood pressure, your insulin resistance, and more importantly, you're in a chronic inflammatory state. The CRP levels of these patients are very high, and that can lead to several microvascular and macrovascular complications. So if somebody has sleep apnea and diabetes, the chances of them developing vascular complications like diabetic retinopathy, like diabetic renal disease, or diabetic, heart disease, neuropathies, any of those is much more than if they don't have sleep apnea, because these other factors, including the intermittent hypoxemia and sleep restriction, are worsening all of these. So once again, this was another study we did with MV diabetes, again confirming that there is a high incidence of sleep apnea in these patients. I wanted to mention about hypertension. A lot of our hypertensives, when they require more than 2 medications, please ask about whether they are snoring and if they have sleep apnea, because they need to be evaluated and treated. And nowadays, the Joint Commission has recommended that one of the common secondary causes of hypertension is OSA. So you need to evaluate for it, particularly if you're having uncontrolled hypertension. And once you start them on treatment, their blood pressure seems to be improving. Again, another study which looked at cardiovascular disease and showed that if somebody is snoring or has sleep apnea, and even if they don't have any other risk factors for heart disease, like they don't have blood pressure, don't have diabetes, don't have hyperlipidemia, even then their risk is much high for the heart disease. Therefore, OSA is an independent risk factor for coronary artery disease. So think about that as one of them. And not only does it lead to coronary artery disease, the chances of heart failure, arrhythmias, particularly atrial fibrillation, is very high in patients with obstructive sleep apnea. So this just wanted to point out once again that sleep apnea is an independent risk factor for obesity, for diabetes, hypertension, and cardiovascular and cerebrovascular disease. And once you are clinically suspecting sleep apnea, you need to do a sleep study, and then depending on how severe it is, if it's moderate or severe, often we recommend CPAP unless there is an obvious obstruction or a surgical correction is required. If it is mild sleep apnea, we predominantly like to go with conservative measures like weight loss, like yoga. Yoga seems to really help, particularly the breathing exercises, pranayamas, and also we consider any of those therapies if they have mild sleep apnea. Okay. So I'm sure all of you remember this book, Charles Dickens' Pickwick, the papers, where when we think about the Pickwick, we think of him as the obese person who's always sitting and sleeping. So that's what our image of obstructive sleep apnea is. But these are people who probably also have obesity hypoventilation syndrome. It is not just obstructive sleep apnea. They are hypoventilating, they are restricting their breathing, and therefore may have high carbon dioxide, which is also leading to their drowsiness or sleepiness during the daytime. So a lot of these patients with obesity hypoventilation will have coexisting sleep apnea, and a small number, about 10% of them, may just be hypoventilating, not have obstructive sleep apnea, and we need to treat them. Now, what are the chances of them having a higher level of carbon dioxide that makes them sleepy? Number one, if they have severe coexisting obstructive sleep apnea, obviously their CO2 levels will be high. But the second most important thing is the higher BMI. Okay, if somebody has significant obesity, so as you can see from here, 30% of individuals with BMI more than 40 will have obesity hypoventilation syndrome. 50% of individuals with BMI over 50 have obesity hypoventilation syndrome. Now, when I mention BMIs of 40 and 50, a lot of you might wonder, do we even see that in India? We absolutely do, primarily because of the height. A lot of them are short and obese, and their BMI is significantly high, so keep that in mind. So this was a study published in New England Journal of Medicine, where they looked at if somebody has sleep apnea, does CPAP alone work, weight loss work, or both, and the combination, and they compared all those models, randomized trial, parallel groups that were done. 24 weeks of either giving them just CPAP, only weight loss, or both. Okay. And all of these were patients with obstructive sleep apnea, at least moderate, and also having a chronic inflammatory state. Their CRP levels were more than 1. About 146 patients were enrolled. The primary endpoint was, did the CRP levels change, when you are giving them these different treatment options. And the secondary endpoint was insulin sensitivity, lipid levels, and also blood pressure. Okay. And it was shown that weight loss made a huge impact on all these patients. And again, I'm talking about when you look at all of them during that period, their weight loss was modest, because like 5% or less. Either weight loss alone or combination of CPAP reduced the CRP, insulin resistance, and serum triglyceride levels much more. And if you only gave CPAP, it did not make a significant difference. I mean, there was some change, but it was not a significant difference in all of these. I'm talking about CRP, insulin resistance, and triglyceride level. However, the blood pressure was reduced in all 3 groups, whether you gave them only CPAP or only weight loss or combination of both. It seems to make a difference. So the reason I wanted to project this study is, yes, sleep apnea needs to be treated with CPAP, but you need to address their weight issues, because that plays a much bigger role in their overall management. So to summarize, sleep apnea is extremely common and often forgotten non-communicable disease. And when you deal with patients who have untreated sleep apnea, it can lead to new onset or uncontrolled hypertension, new onset or uncontrolled diabetes, accelerated atherosclerosis, which is what leads to coronary and cerebrovascular disease. And treatment improves metabolic complications and vascular comorbidities. And if you can combine weight loss in overweight patients along with the treatment for OSA, you have much better effects than just like treating them with CPAP. I'll stop with that. I hope all of you have a good night, because a good night is essential for a good day. Thank you all. Happy to take any questions.
Can you give a still before doing a sleep study?
Okay. So if somebody is used to taking medications, we don't stop it, because then they will not sleep at all on the night of the study. If they are not using medications, we don't give them a sleep pill. The reason for that is that's their natural sleep, and you'll be surprised. Some of them will say, how will I sleep with all these wires and all that? They have sleep apnea, 100% they would come and sleep. They will have no issues. So if they're on chronic medications, we don't stop them.
How good is melatonin?
Yeah. So melatonin is, in my opinion, very good for circadian rhythm issues. Like, for example, jet lag. I'm taking melatonin for the past 3 days to help reset my cycle. So it definitely helps for rhythm disturbances. Unfortunately, it is being thrown away too easily as a something that's non-addictive, and like people are beginning to use that for insomnia a lot. It will help, but it's not recommended for long-term use. That's what I would say. The one thing I want to specifically mention about melatonin is, if a low dose doesn't help, higher dose will not help. So if in India, fortunately, it's available as 3 milligrams. In the US, it's available up to 10, 3, 5, 10. So I usually give just half a tablet of 3, because 1 milligram was the dose studied in most of the circadian rhythm disturbance. So you can use it for a short period of time.
How good is it? Eye blinders?
Definitely helps in people who are very sensitive to the light, and also the blue light filters seem to help. But if you have a lot of screen time, it definitely makes a difference. Yeah. And see, in a couple, when we are co-sharing a bed, the preferences are very, very variable. One wants the AC, the other one does not want AC. The fan makes too much noise for one. Somebody doesn't like the light; it has to be dark. Somebody wants bright light. So like, you would be amazed at the number of couples who don't sleep together. Okay, so people, yeah. So no, that's what happens a lot of the times. Unfortunately, it does affect their personal life in a lot of ways. But what I was trying to say is, if you need a light in the room and you are very sensitive, using eye shades definitely will help. There are people who say that the spouse is snoring and they put earplugs because they are otherwise unable to sleep in the same room. So you can use these other modes for.
Majority of the patients are on antidepressants.
Yes.
And how do you correlate with the person? You find, do they actually cause primary cause, or it might aggravate the obesity?
So the good thing with antidepressants is that they may get better sleep. The bad thing with antidepressants is 90% of them cause weight gain. Like most people forget that. Like most of the antidepressant medication, will cause weight gain, and it will be very subtle, and that's what when we talk about weight gain as a risk factor for sleep apnea, it's not only being obese, it's also recent weight gain. There are people who will clearly come and tell me, I started gaining weight, since then my wife is saying I'm snoring, or my husband is saying I'm snoring. So it's known for that. And also benzodiazepines can worsen sleep apnea. So we don't, like if somebody has severe OSA, if I can avoid, because obviously, if they're also having severe anxiety and, depression, and they need those, I cannot stop it. But we can reduce it, or use some other medications. The one that has been shown to have least impact is S-zopiclone, not even zolpidem, but S-zopiclone has anti-obesity.
Obesity and hypothyroidism. Even after taking 150 or 200 microgram thyroxine, they still have their body weight at a higher level. There is no reduction in them.
Ma'am, I'm sorry to say that most people blame hypothyroidism for their obesity. That's not the only reason. So, yes, hypothyroidism can cause increase in weight, and it may, once you treat it, it may come down a little bit. But that's not the only reason or the primary reason. So you'll have to address other things for. There are so many. I totally agree with you. So many people completely get treated that thyroid functions are normal, but still they will not lose weight. So you will have to push them on the diet and exercise patterns.
Having a walk before bed helps.
No, we don't recommend aggressive exercise at least about 2 to 3 hours before bedtime. So in fact, I don't think gyms should be open around the clock. But again, there are people who are working different shifts and they come at different times. But we don't recommend that in the night.
Screen time before sleep
Will definitely worsen sleep. So again, at least 1 hour before, we recommend avoiding it. And if you definitely avoid TV in the bedroom, like using laptops and all that. But more importantly, we also tell people that if you are watching TV or reading, having bright light, do not lie down in bed and do that. Like do that outside, and when you're ready to sleep, go to bed. It's just an association factor. Like we associate everything with something. Like you have a brush, you'll only brush with it, you'll not eat it. So similarly, the bed is meant only for sleep or intimacy with your partner, nothing else. You are asking about your weight loss medications.
We had one patient who was police SSY. Her BMI was more than 40 and her apnea index was more than 15. And she was on CPAP and she developed pulmonary hypertension also. Because she was not taking CPAP properly, which they with preservative conditions. So we followed up with and motivating her to have the weight reduction on this. We followed the for 1 month.
Yeah, I hear you.
So in 1 month we followed up, and but still she had that problem again. But what we did is next month when she came to our follow for pulmonary hypertension off level we have started her on single level, and for anti-obesity we have given this Orlis step, and she had weight reduction and she had more improvement. What is your comment, sir? Whether you can use Orlis step, and I want to know the complication because I'm using it me. Because without knowing the complications, I can't give much.
Sure.
So she came back with 2 weeks with far better. Now she's walking and she's better. So your experience.
Okay. So first of all, with regards to, please announce, sir, you can ask me. So First of all, with regards to using medications purely for weight reduction, I do not recommend that, and generally the obesity guidelines do not recommend that without a trial of non-medication efforts, like diet, like exercise. And people are not as compliant as we think. They'll come and say, oh, I don't eat much. You ask anybody and all that. I'm not promoting their product, but this is where it helps to closely observe, track them, follow them, so that on some format, make sure that they are complying with the diet, make sure that they are complying with their exercise patterns, so that they will lose weight. Usually we recommend, I mean, this is almost like chronic liver disease and alcohol, like you don't list them for transplant unless they have stopped alcohol for at least 6 months. So similarly here, at least for 6 months, I do not even put them on any medications unless they're already on something like metformin for diabetes, which is also thought to be a weight loss drug. Okay, so that is okay. Now, a lot of them, now with all these semaglutide and all of those medications, they are expensive, but some of the diabetologists are preferring to use that. In fact, at one stage, bariatric surgeons were marketing surgery as a diabetes. You can be free of diabetes if you are. So basically, what you are trying to do is achieving weight loss through different methods. So the form or the protocol should be first try like conservative measures, diet, exercise strictly, and then move on to giving medications. If despite that, I mean, with people who are super obese, the 50s and all the BMIs, those kind of patients, you may have to keep alerting them that at some stage you're going to need medications and you may end up needing surgery also. But none of these are quick fixes. Like medications come with their own side effects. Orlistat, I'm surprised that your patient is tolerating. A lot of people have, bloating, they have, loose stools. That's the commonest problem with orlistat. But that was the only one that was available for a long time here. But now, the semaglutide and again, once a week injections are available. So there are options. But if you look at all studies, the weight loss with them is also modest. So they cannot rely only on that. It has to be a combination. And even bariatric surgery is a change of life. It is not like you go and chop off a piece of your stomach and they have to completely change their mindset. It's a lifestyle change. If they start eating more and more, they'll distend the pouch. And I have seen people who have had bariatric surgery, had significant weight loss, but at some stage start eating more and gradually the pouch gets stretched and they go back to their previous weight. I'm sure that. So nothing is easy when it comes to weight management. And also we need to be reasonable. See, each one of us has a certain body frame. Like you can't expect. That's where the BMI becomes a problem sometimes. We just go by the height and weight. There are certain body frames where you cannot reduce beyond. That's why we say healthy weight. If your comorbidities are getting better and this is what it is, that's what you need.
The role of the semaglutide in non-diabetic obese patients.
It
What
is.
your opinions?
It is being studied. In fact, there was one recent study on another glutide where they found that like it definitely seems to help in people with other obesity-related problems. It's not just diabetes. See, I mean, obesity, the other comorbidities are early osteoarthritis, like people have trouble walking. In fact, they're not able to do the exercise, what we tell them, because they're unable to cope with all of that. So we use, even in non-diabetics, we can use the semaglutide for this. And the incidence of hypoglycemia and all is very low, surprisingly. Like that's what would come to our mind immediately, when we are using. It doesn't happen. Because they have high insulin resistance just because of their obesity.
Any drug to reduce dreams tonight?
Less sleep. No. So yeah, we can use REM suppressing agent. We don't use that routinely because, as I said, we remember only dreams during REM sleep. So if we suppress REM with any of the antidepressants, sometimes the dreams will be less. We don't do that. I'm just saying. The only other time where we do treat, dreams is post-traumatic stress disorders. In them, we can use some phentolamine. Any of those can also reduce their nightmares and.
CPAP, how long you should do? Is it lifelong?
So I always tell everyone that assume it is lifelong unless there is a risk factor that you are completely able to correct. For example, alcoholism. Like it's very well known that people will snore more and have more apneas on the night that they consume alcohol. Okay. So if somebody is alcoholic, they're able to come off that. I've had some patients come off CPAP. Obesity is another big thing. I've had people with aggressive weight loss, and you're talking about years. They didn't do it like overnight or anything. After about 5 or 6 years, when they have lost enough weight, we follow them, and when the pressure requirement on the CPAP keeps coming down, then we try to repeat a sleep study, and if they are free of sleep apnea, I tell them you can try without CPAP. But 90 to 95% of the patients may require it lifelong. Okay. And there are a few with underlying risk factors that are correctable who will come off. Sure. I don't know about the time. You'll have to tell me to stop. So. No.
So this is like practical difficulty which I am facing from my PG days in government. So first I divided into three. One is what one patient says that who is a normal patient, he didn't have any problem, asymptomatic patient who says that I can't sleep. That is the first patient. Second patient is in ICU. We have in an ICU setup where he has no comorbid patient, some poison he has taken, so delirium is there. Third is if a patient has any cardiac and renal complication who is not having sleep properly. In these three setups, what medicines you prefer, sir, for the patient who is having sleeplessness at night?
Okay. So it's very difficult to answer broadly. Okay, so I'm just going to be very brief in the interest of time. See, you can't just go by sleeplessness. You'll have to find out if there's an underlying reason and whether it is short term or long term. Like a lot of people in the ICU setup don't sleep. We use melatonin there fairly frequently. If they have delirium along, then we use quetiapine or something like that fairly often in the ICU as an ICU doctor. So those are all for short term when you're using. If somebody has that underlying problem and still for a short time and no other reason, like they're not depressed, they're not having anxiety, then using what we call the Z drugs, the zolpidem, zopiclone is probably a better way to handle them. But you would be surprised if you do a detailed analysis, a lot of them will have underlying anxiety or depression, which also needs to be addressed with counseling or CBT, cognitive behavioral therapy. Thank you.
Thank you very much.
Thank you so much.
Give a big hand for